Panic and Obsessions 2. Structure 3.0 Introduction 3.1 Generalized 3.0 Introduction. As you learned in the previous unit, there are several anxiety disorders that have been identified by DSM-5, like generalized anxiety disorder, specific phobia, social phobia, panic disorder, and agoraphobia. The clinical aspects, causal factors and treatment of specific phobia, social phobia, panic disorder, and agoraphobia were covered in the previous unit. In this unit, you will learn the clinical features, causal factors and treatment of generalized anxiety disorder and obsessive-compulsive disorders. Previous DSMs classified obsessive-compulsive disorder, OCD, as an anxiety disorder. However, DSM-5 has listed it under a separate category, named as obsessive-compulsive and related disorders. Let us learn about these disorders in detail. 3.1 Generalized anxiety disorder. Generalized anxiety disorder, GAD, is a state of chronic, excessive and unreasonable worry about multiple life events or activities. Since anxiety is not Dr. Gulguna Jamal, Assistant Professor, Zakir Hussain College, University of Delhi, New Delhi. AD. Introduction to Psychological Disorders and Disorders of Anxiety and Obsessions. Anchored to a specific object or situation as in phobias, it was earlier described as free-floating anxiety, Butcher, Hooley, Manika, and Dwivedi, 2017. Individual with GAD is persistently anxious often about minor things, and worry chronically, Davison, Neal, and Kring, 2004. People with GAD spend a great deal of time worrying about a wide range of topics and describe their worrying as uncontrollable, Ruskio, Borkovic, and Ruskio, 2001. 3.2 Clinical features of generalized anxiety disorder. The clinical features of GAD, according to DSM-5, have been explained in the box 3.1. Box 3.1, DSM-5 Criteria for Generalized Anxiety Disorder, APA, 2013. A. Excessive anxiety and worry, apprehensive expectation, occurring more days than not for a period of at least 6 months, about a number of events or activities, such as work or school performance. B. The person finds it difficult to control the worry. C. The anxiety and worry are associated with 3 or more of the following 6 symptoms, with at least some symptoms present for more days than not for the past 6 months. Note: only one item is required in children. 1. Restlessness or feeling keyed up or on edge. 2. Being easily fatigued. 3. Difficulty concentrating or mind going blank. 4. Irritability. 5. Muscle tension. 6. Sleep disturbances, difficulty falling or staying asleep, or restless. Unsatisfying sleep. D. The focus of the anxiety and worry is not confined to features of an axis I disorder. Example: the anxiety or worry is not about having a panic attack, as in panic disorder, being embarrassed in public, as in social phobia, being contaminated, as in obsessive-compulsive disorder, gaining weight, as in anorexia nervosa, having multiple physical complaints, as in somatization disorder, or having a serious illness, as in hypochondriasis, and the anxiety and worry do not occur exclusively during post-traumatic stress disorder. E. The anxiety, worry, or physical symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. F. The disturbance is not due to the direct physiological effects of a substance, example: a drug of abuse, a medication, or a general medical condition, example: hyperthyroidism, and does not occur exclusively during a mood disorder, a psychotic disorder, or a pervasive developmental disorder. Note: no changes were made from DSM-IV to DSM-5. 81. Disorders of anxiety, panic and obsessions. 2. Comorbidity. GAD is associated with functional impairment and increased risk of adverse health outcomes, including cardiovascular disease and suicide, Keller, 2002. It is also frequently found in conjunction with other psychiatric conditions, including depression, Wells and Butler, 1997, Brown and others, 2001, panic disorder, post-traumatic stress disorder, and social phobia, Kessler and Witchen, 2002. Prevalence. GAD is common, with a prevalence rate of 3% for a period of any one given year and a lifetime prevalence of 5.7%. Kessler, Berglund, Dealer, and others. 2005. Lifetime prevalence in India is 5.8%, Chandrasekhar and Reddy, 1998. Age of onset. Nearly 60 to 80% people with GAD report that they have been anxious for as long as they remember, whereas many others have reported a slow and insidious onset. Romer and others, 2002. It is difficult to determine the age of onset, but research has suggested that older adults often develop it, and it is the most common anxiety disorder for them. Example, McKenzie and others, 2011. Course. GAD is a chronic disorder. A 12-year follow-up study reported that 42% of the people diagnosed with GAD did not remit even after 13 years, and nearly 50% of those who remitted had a recurrence. Bruce and others, 2005. Though it tends to disappear after age 50 for many people, it is usually replaced by somatic symptoms disorder with physical health concerns. Rubio and Lopez Ibor, 2007. It is a common and a chronic disorder. However, in spite of high levels of worry and perceived low well-being, most of the people with GAD manage their lives, though with some role impairment. As compared to panic disorder or major depressive disorder, which are more debilitating disorders, people with GAD are less likely to avail the psychological treatment facilities, because they usually visit physicians with physical complaints like muscle ache, gastrointestinal problems, etc. Hoffman and others, 2010. Gender ratio. GAD is twice as common in women as in men. Rickles and Sheveiser, 1997. General characteristics of people with GAD. People suffering from GAD live in a relatively constant state of diffuse uneasiness, tension, and worry. They are almost always in an anxious apprehension, defined as a future-oriented mood state in which a person constantly attempts to be ready to deal with any upcoming negative events. There is chronic over-arousal along with high levels of negative affect, and a sense of uncontrollability. Barlow and others, 1996. Decision-making is difficult as they have poor concentration and dread to make mistakes. They often unsuccessfully attempt to avoid anxiety by procrastinating or indulging in checking activities. They are hyper-vigilant for all possible signs of threat in their environment. There are frequent complaints of muscle tension and aches in the neck and upper shoulder region. 82. Introduction to Psychological Disorders and Disorders of Anxiety and Obsessions. Sleep disturbances, such as insomnia, nightmares, and sometimes hypersomnia, excessive sleep, to escape from anxiety are often reported. Such people feel upset, uneasy, and discouraged due to constant worries. Family, finances, work, and personal illness were found to be the most common life areas of worry. Roman, Molina, and Borkovic, 1997. Decision-making is difficult for them and they worry endlessly over possible errors that they might have made while deciding. Real and imagined mistakes committed currently or in the past are often reviewed after going to bed. All the possible future difficulties are anticipated by them. They are unable to logically think that it is useless to trouble oneself with future outcomes which are beyond one's control. And failure to control their tendency to worry gives them a feeling of helplessness. 3.3 Causal Factors. Why does GAD develop? There are many possible causes of GAD to develop. They are re-indicated as follows. Biological perspective. Genetic factors. There is mixed evidence for genetic factors. However, a modest genetic component for GAD has been reported. Hetima, Neal, and Kendler, 2000. Among the research studies carried out so far, one of the largest and most recent twin studies has reported a variance of 15 to 20% in liability to GAD due to genetic component. In other words, there is higher concordance rate for GAD in MZ than DZ twins. Further, strong evidence has been found for a common underlying genetic predisposition for GAD and major depressive disorder MDD. Kendler and others, 2007. Nevertheless, whether a person with a genetic risk for GAD or MDD will develop the disorder is determined by the environmental factors, non-shared environment. A basic personality trait called neuroticism has been conceptualized as the common underlying predisposition for developing GAD and MDD. Kendler and others, 2007. Neurochemical and neurohormonal factors. Neurobiological model is based on the research conducted between 1950s and 1970s on the operations of benzodiazepines, a group of drugs that are effective in the treatment of anxiety. Researchers discovered a receptor in the brain for benzodiazepines that is linked to the inhibitory neurotransmitter gamma-aminobutyric acid or GABA. In normal fear reactions, neurons throughout the brain fire and create the experience of anxiety. This neural firing also stimulates GABA system, which inhibits this activity and reduces anxiety. GAD may result from some defect in the GABA system so that anxiety is not brought under control. The benzodiazepines may reduce anxiety by enhancing the release of GABA. GABA, serotonin and norepinephrine have been suggested to play a role in anxiety, Lados, 2002. But their interaction remains largely unknown till date, Butcher and others, 2017. The corticotropin-releasing hormone, CRH. The CRH plays a role in GAD as it is an anxiety-producing hormone. When CRH is activated by stress or perceived. 83. Disorders of anxiety, panic and obsessions too. Threat, it stimulates the pituitary gland which in turn releases the adrenocorticotropic hormone, ACTH. The ACTH stimulates the adrenal gland which in turn releases the stress hormone called cortisol. The CRH is believed to play an important role in GAD as it has been discovered to affect the bed nucleus of the extension of amygdala which mediates generalized anxiety, Davis, 2006. Psychoanalytic perspective. Generalized anxiety is the result of a constant unconscious struggle between id impulses and ego. Id impulses are aggressive and sexual in nature, and struggle for expression, whereas the ego, because of its unconscious fear of being punished, does not let id express its desires. Since the source of anxiety is unconscious, person does not know the reason for anxiety and as a result is always anxious and apprehensive. The person cannot evade anxiety as she cannot escape from id, for escape from id means that the person is no longer alive. Furthermore, since anxiety is not displaced onto a specific object or situation as it happens in the case of phobia, hence the person is anxious nearly all the time. But due to lack of empirical verification, this viewpoint is not clinically accepted. Behavioral perspective. According to Wolpe, 1958, the elicitors of anxiety may be environmental factors, example, other people or social situations. A person who spends most hours of his/her day with other people may be anxious because of the people or the social situations and not because of any internal factors, that is, the person learns to associate their anxiety with the presence of other people. Cognitive behavioral perspective. The main underlying idea is that GAD results from distorted cognitive processes. People with GAD often misperceive benign events, such as crossing the street, as involving threats, and their cognitions focus on anticipated future disasters, Beck and others, 1987. Their attention is easily drawn to threatening stimuli, Mogg, Miller, and Bradley, 2000. Studies have shown that in contrast to non-anxious people, generally anxious people tend to notice threat cues when presented with a mixture of threat and non-threat cues, Manika and others, 1998. Furthermore, they are more inclined to interpret ambiguous stimuli as threatening and to rate ominous events as more likely to occur to them, Butler and Matthews, 1983. The heightened sensitivity to threatening stimuli occurs even when the stimuli cannot be consciously perceived, Bradley and others, 1995. Uncontrollable and unpredictable aversive events are much more stressful and hence more anxiety-provoking than the controllable and predictable events. People with GAD may have a history of experiencing many important life events as unpredictable and uncontrollable, Manika and Zinbarg, 1998. Early experience with control and mastery can immunize to some extent against the harmful effects of exposure to stressful situations and may in turn immunize against GAD, Barlow and others, 1998. Borkovic and others, 1998, have proposed another cognitive view as they focused on the various functions served by worry. Worry can be negatively reinforcing. It may serve 5 positive functions for people with GAD. Superstitious avoidance of catastrophe. Worrying will lessen the likelihood of a feared event. 84. Introduction to psychological disorders and disorders of anxiety and obsessions. Actual avoidance of catastrophe. Worrying helps to generate ways of avoiding catastrophe. Avoidance of deeper emotional topics. Worrying distracts from more troublesome emotions. Coping and preparation, and motivating device, helps in motivating oneself to work. A subset of people with GAD believe that worry has positive functions, which in turn helps in maintenance of high levels of anxiety, Dugas and others, 2007. Worrying is self-sustaining as it does not produce much emotional arousal, example, it does not produce the physiological changes that usually accompany emotion, and it blocks the processing of emotional stimuli. Despite its positive functions, worry has some negative consequences as well. Newman and Lira, 2011. Worry is not an enjoyable activity as it involves thinking about the negative catastrophic outcomes and can lead to a greater sense of anxiety and danger. According to Wells and Papagiorgio, 1995, it may lead to more intrusive thoughts as they found in a study that involved 3 groups watching a gruesome movie in 3 conditions. After watching the movie, one group was told to relax, the second group was told to imagine the events in the movie, and the third group was asked to verbally worry about the movie. It was found that people in the third group had more intrusive thoughts as compared to the other 2 groups after several days of watching the movie. Worrying also leads to more intense negative emotions. Newman and Libera, 2011. Further, there is evidence for paradoxical effect of worry also, that is, attempts to control worry leads to more intrusive thoughts which lead to a feeling of uncontrollability. This in turn leads to anxiety which further enhances worry. Thus, it leads to a vicious cycle of worry, intrusive thoughts and anxiety. Manika and Zinbart, 2006. 3.4 Treatment of GAD. Psychological therapy and medication are used as treatment options for GAD. Cognitive behavioral therapy, CBT, as has been described in the above sections. CBT uses a combination of behavioral techniques such as progressive muscle relaxation exercises to relieve the physiological symptoms, such as breathlessness, muscle tension, and cognitive techniques, such as cognitive restructuring, for dealing with the psychological symptoms, such as anxiety, cognitive distortions, catastrophizing, etc. Barlow, Allen, and Basden, 2007. Though GAD has been known as one of the most difficult among anxiety disorders to treat, nevertheless, Research Review has found the CBT to successfully alleviate the symptoms of GAD, MIDI, 2005. Interestingly, research has shown CBT to be as effective as benzodiazepines, and it has also helped to taper off long usage of medication, Gosselin and others, 2006. Medications. Often, people suffering from GAD consult general practitioners, GPs, for somatic systems such as muscle aches, tingling sensations, numbness, breathlessness, etc. and are prescribed benzodiazepines or anxiolytics, such as Alprax, Ristrol, market names. These drugs lead to symptom relief, and are more effective in alleviation of physiological rather than psychological symptoms. But these drugs can lead to psychological and physiological dependence. Buspirone is a new drug which is more effective in alleviating psychological symptoms like anxiety and does not lead to sleepiness and psychological or 85. Disorders of anxiety, panic and obsessions too. Physiological dependence, but it takes a longer time, 2 to 4 weeks, to show effect. Roy Byrne and Cowley, 2007. Similarly, some antidepressants have also proved to be beneficial in treating GAD, but these also take a long time, several weeks, to show their effect. Goodman, 2004. Check your progress. 1.1. List the characteristics of GAD. Thank you for listening. Please like and subscribe our channel. 2. Explain the psychoanalytical perspective for the development of GAD. Thank you for listening. Please like and subscribe our channel. 3. What are the treatment options for GAD? Thank you for listening. Please like and subscribe our channel. 3.5 Obsessive-Compulsive Disorder. Obsessive-Compulsive Disorder, OCD, is characterized by the occurrence of unwanted, intrusive obsessive thoughts and distressing images which are usually accompanied by compulsive behaviors. Compulsive behaviors are carried out either to undo or neutralize the obsessions or to prevent the occurrence of some dreadful event. 3.6 Clinical aspects of OCD. Obsessive-Compulsive Disorder, OCD, is now included in DSM-5 under the category of obsessive-compulsive and related disorders. Other disorders included are hoarding disorder, excoriation, skin-picking disorder, body dysmorphic disorder and trichotillomania, compulsive hair pulling. Many of us may occasionally find ourselves indulging in repetitive or stereotypical behaviors such as checking locks or gas stove. However, it does not mean that we suffer from OCD. Obsessive-compulsive disorder involves much more excessive, persistent and distressing thoughts and the associated compulsive acts that significantly interfere with everyday activities. See box 3.2 for DSM-5 criteria. 86. Introduction to Psychological Disorders and Disorders of Anxiety and Obsessions. Box 3.2. Criteria of Obsessive-Compulsive Disorder, DSM-5, APA, 2013. A. Presence of obsessions, compulsions, or both. Obsessions are defined by 1. And 2. 1. Recurrent and persistent thoughts, urges, or images that are experienced, at some time during the disturbance, as intrusive and unwanted, and that in most individuals cause marked anxiety or distress. 2. The individual attempts to ignore or suppress such thoughts, urges, or images, or to neutralize them with some other thought or action, that is, by performing a compulsion. Compulsions are defined by 1. And 2. 1. Repetitive behaviors, example, hand-washing, ordering, checking, or mental acts, example, praying, counting, repeating words silently, that the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. 2. The behaviors or mental acts are aimed at preventing or reducing anxiety or distress, or preventing some dreaded event or situation. However, these behaviors or mental acts are not connected in a realistic way with what they are designed to neutralize or prevent, or are clearly excessive. Note: young children may not be able to articulate the aims of these behaviors or mental acts. B. The obsessions or compulsions are time-consuming, example, take more than 1 hour per day, or cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. C. The obsessive-compulsive symptoms are not attributable to the physiological effects of a substance, example, a drug of abuse, a medication, or another medical condition. D. The disturbance is not better explained by the symptoms of another mental disorder, example, excessive worries, as in generalized anxiety disorder, preoccupation with appearance, as in body dysmorphic disorder, difficulty discarding or parting with possessions, as in hoarding disorder, hair pulling, as in trichotillomania, hair pulling disorder, skin picking, as in excoriation, skin picking disorder, ritualized eating behavior, as in eating disorders, preoccupation with substances or gambling, as in substance-related and addictive disorders, preoccupation with having an illness, as in illness anxiety disorder, sexual urges or fantasies, as in paraphilic disorders, impulses, as in disruptive, impulse control, and conduct disorders, guilty ruminations, as in major depressive disorder, thought insertion or delusional preoccupations, as in schizophrenia spectrum and other psychotic disorders, or repetitive patterns of behavior, as in autism spectrum disorder. According to DSM-5, obsessions involve persistent and recurrent intrusive thoughts, images, or impulses that are experienced as disturbing, inappropriate, and uncontrollable. People who have such obsessions actively try to resist or 87. Disorders of anxiety, panic, and obsessions to suppress them or to neutralize them with some other thought or action. Compulsions can involve either overt repetitive behaviors that are performed as lengthy rituals, such as hand-washing, checking, putting things in order over and over again. Compulsions may also involve more covert mental rituals, such as counting, praying, or saying certain words silently over and over again. A person with OCD usually feels driven to perform this compulsive, ritualistic behavior in response to an obsession, and there are often very rigid rules regarding exactly how the compulsive behavior should be performed. The compulsive behaviors are performed with the goal of preventing or reducing distress or preventing some dreaded event or situation. OCD lowers the quality of life and leads to significant functional impairment, and thus it is often considered to be one of the most disabling mental disorders, Stein and others, 2009. Unlike schizophrenia, in which absence of insight is a characteristic feature, the person suffering from OCD must recognize that the obsessions and compulsions have not been imposed externally but are the product of his or her own mind and are senseless and excessive. However, this insight may be absent in a minority of cases, Ruscio and others, 2010. As mentioned above, many of us may experience obsessions and compulsive behavior occasionally, but the diagnosis of OCD implies spending at least 1 hour in obsessional and compulsive activities and most of the waking hours in severe cases. But research has shown that normal and abnormal obsessions and compulsive behaviors are placed on a continuum in terms of differing frequency, intensity, troublesomeness, and the degree of resisting the obsessions and compulsions. Example, Steketty and Barlow, 2002. More than 25% of people in the National Comorbidity Study, NCRR, were found to have experienced obsessions or compulsions at some point in their lives by Ruskio and others. 2010. Obsessive thoughts involve themes like fears of contamination, harming oneself or others, pathological doubt, need for symmetry, religious, aggressive and/or sexual obsessions. These themes have been reported to be consistent across cultures and lifespan. Palanti, 2009. Aggressive or violent themes often involve thoughts of harming close family members, such as poisoning a spouse or children, and though rarely acted on, such thoughts torment the person who has such thoughts. To deal with such tormenting thoughts, people with OCD are often compelled to indulge in meaningless and sometimes absurd activities known as compulsions. There are 5 primary compulsive behaviors: cleaning, washing, checking, ordering, arranging, and counting. Matthews, 2009. At a given time, different kinds of compulsive behaviors may be shown by people. Some people may show extreme slowness in performing daily chores, while others may insist on having things in a strictly symmetrical fashion. Matthews, 2009. Washing or cleaning may range from washing hands for 15 to 20 minutes, with only water or general soap, to several hours of washing hands with detergents or disinfectants. This may lead to bleeding hands with scaling and peeling skin. Similarly, checking rituals may range from mild, checking for lights, locks, etc., twice or thrice a day, to extreme checking, where people would go back to their third-floor apartment after reaching the basement parking and repeatedly indulge in the same behavior, so that they are unable to perform the activity that they were supposed to do. Since both cleaning and checking rituals are carried out a specific number of times, so these also involve repetitive counting. Although, performing the compulsive acts lead to reduction in anxiety and a sense of control, but the relief. 88. Introduction to psychological disorders and disorders of anxiety and obsessions is short-lived, and so the person has to keep on repeating the act. Example, Purdon, 2009. Comorbidity with other disorders, mood and anxiety disorders. Example, social phobia, panic disorder, GAD, and PTSD, often co-occur with OCD. Matthews, 2009. Several research studies have reported that 25 to 50% of people with OCD are likely to experience major depression at some point in their lives. Further, significant depressive symptoms are likely to be found in approximately 80% of people with OCD. Torres and others, 2006. One plausible reason suggested for co-occurrence of depression is that it could be a patient's response to the chronic and debilitating nature of OCD. Further, the dependent and avoidant personality disorders can also co-occur with OCD. Body dysmorphic disorder, BDD, has also been found to co-occur frequently with OCD. Example, a study found body dysmorphic disorder in 12% of patients with OCD. In fact, researchers have suggested a close relationship between OCD and BDD. Example, Phillips and others, 2007, 2010. Veal and Nazirolu, 2004. Prevalence, age of onset, and gender differences. The prevalence rate of OCD was 1.2%, and the lifetime prevalence was 2.3% in the National Comorbidity Survey Replication Study, Ruskio and others, 2010. However, some studies have reported a lifetime prevalence of 3%, Kessler and others, 2009. Both obsessions and compulsions are experienced by 90% of the patients with OCD, Franklin and FOA, 2007. Obsessive-compulsive disorder leads to disturbed interpersonal and occupational relationships, which might be a reason for an overrepresentation of divorced and/or separated and unemployed people among the patients with OCD, Torres and others, 2006. Unlike other anxiety disorders where more females suffer than males, no significant gender difference has been reported. The onset age is usually late adolescence or early adulthood, when prevalence is also the highest. However, OCD can be found in children also with symptoms like adults, Poulton and others, 2009, with higher prevalence, heritability, and severity among boys than in girls, Lomax and others, 2009. Often the onset is gradual, and it tends to be chronic once the symptoms become severe. Example, Matei Calls and others, 2002. 3.7 Causal Factors of OCD. The main causal factors of OCD are as follows. Biological factors. Genetic component. In a twin study, concordance rates of 68% and 31% were found for 80 pairs of monozygotic and 29 pairs of dizygotic twins, respectively, which indicates a moderate heritability of OCD, Van Groothuist and others, 2007. In family studies, prevalence rate of OCD in first-degree relatives of proband has been found to be 3 to 12 times higher than the normal population, Grabe and others, 2006. Further, genetic component is significantly stronger in the early onset of OCD than in the later onset of OCD, Grisham and others, 2008. Also, tic-related OCD in childhood, which is linked to Tourette's syndrome, has also been found to have a significant genetic component, Lochner and Stein, 2003. For example, OCD was found in 23% of first-degree relatives of patients with Tourette's syndrome, Pauls and others, 1995. Lastly, the field of molecular genetics has found specific genes for OCD that are different from Tourette's syndrome, Grisham and others, 2008, Stewart and others, 2007. 89. Disorders of anxiety, panic and obsessions 2. Structural and functional abnormalities of brain. Brain imaging of OCD patients has shown abnormalities in cortical and subcortical regions such as the basal ganglia. PET scans have also shown higher levels of activity in orbitofrontal cortex and cingulate gyrus. In turn, all these structures are connected to the amygdala, thalamus, and the limbic system. This brain circuitry is responsible for the activation of primitive behaviors such as hygiene, aggression, and sex. Symptoms of OCD lead to increased activation of this brain circuitry, Evans, Lewis, and Lobst, 2004. Successful treatment of OCD shows some normalization of this brain circuitry, Saxena and others, 2002. The central themes for obsessions, such as sex, aggression, danger, and hygiene, originate in the orbital frontal cortex, Baxter and others, 1991. The cortica-basal ganglionic thalamic circuit allows only the strongest of the primary urges to pass through and reach the thalamus, which is the relay station. All sensory input is received by the thalamus, which then passes that sensory input back to the cerebral cortex. Baxter and others, 1991-2000, have proposed that abnormal functioning of the cortica-basal ganglionic thalamic circuit due to overactivation of orbitofrontal and cingulate cortical regions does not allow the controlled passage of information, with the result that all the messages, even subtle ones, regarding hygiene, aggressions, etc., pass through. This leads to inappropriate behaviors, such as repetitive behaviors in response to concerns like aggression, hygiene, etc., thereby leading to obsessional and compulsive behavioral pattern. Research evidence, example, Zheshko and others, 2004, Yu and others, 2007, has suggested that one possible reason for abnormal circuitry can be the abnormalities in white matter in the brain areas that form this circuit. Neurochemistry of brain. Indirect evidence for the involvement of serotonergic system in OCD came from the pharmacological studies. Example, in 1970s a tricyclic antidepressant called clomipramine was found to be an effective treatment for OCD. Although other tricyclic antidepressants are also available, but clomipramine has been found to be most effective as it has significantly greater effects on serotonin, Doherty and others, 2007, Stewart and others, 2009. Also, selective serotonin reuptake inhibitors, SSRIs, have also proved to be effective in treatment of OCD, Doherty, Roch, and others, 2002, 2007. Interestingly, increased serotonergic activity leads to OCD symptoms. Then how these antidepressants, which lead to an increase in the serotonin level, could treat OCD. The antidepressants such as tricyclics and SSRIs in a short-term use increase the serotonin levels, but when taken for longer duration, 6 to 12 weeks, leads to downregulation of serotonin receptors, causing a functional decrease in the serotonin levels, which helps in controlling the symptoms of OCD, Dolberg and others, 1996. GABA, glutamate and dopaminergic systems are also suggested to be involved in OCD. However, their exact role is yet to be established, Stewart and others, 2009. It can be concluded that biological factors such as genetic components, structural and neurochemical abnormalities of brain have been found to be involved as causes in OCD. However, the exact nature and contribution of these factors in OCD are yet to be established. Psychological factors learning theory. Maurer, 1947, has explained the obsessive-compulsive disorder through his two-process theory of avoidance learning. In the first step, through classical conditioning, the neutral stimuli get associated with frightening thoughts and elicit anxiety. For example, a person associates behaviors like 90. Introduction to psychological disorders and disorders of anxiety and obsessions. Touching a door handle or brushing of clothes against the wall, floor with infection and so develops fear of contamination. In the second step, the person tries to prevent infection by washing hands or clothes, which also reduces the fear of contamination. Thus, the person learns that washing behavior is effective in anxiety reduction, thereby reinforcing the washing response. In future, the person would indulge in washing behavior whenever she feels anxious about contamination. Rachman and Shafran, 1998. Since such behaviors reduce anxiety, hence these are extremely resistant to extinction. Manika and Zinbart, 2006. Animals and humans have been reported to indulge in avoidance behavior frequently when they face stressful and anxiety-provoking events. Example, Cromer and others, 2007. In support of this theory, Rachman and Hodgson, 1980, conducted several studies. They purported that although an anxiety-eliciting situation may provoke many of us, but people with OCD are forced to perform some action repeatedly to reduce anxiety caused by an obsession. Despite realizing the futility of her obsessions and related compulsive behaviors, the person is unable to control such compulsive behaviors because these lead to reduction in anxiety caused by the obsessions. Thus, this model suggests that exposure to the anxiety-provoking situation without allowing the person suffering from OCD to indulge in an anxiety-reducing compulsive act will help in treatment. The underlying reasoning is that when the person will find their anxiety subsiding on its own without indulging in any compulsive act, it will help them realize the futility of their compulsions. Rachman and Shafran, 1998. This model helps us to understand the maintenance of the obsessive-compulsive behavior. However, it is silent on the causal factors. Cognitive perspective. The paradoxical effect of thought suppression helps us to understand the cause of OCD. It has been shown experimentally that attempts at suppressing of thoughts in normal people often leads to increase in those thoughts later. Abramowitz and others, 2001. Wegner, 1994. People with OCD differ from normal people with respect to the degree of thought suppression. That is, people with OCD find it more difficult to suppress their thoughts, and failure at thought suppression leads to negative mood. In a study, people with OCD were asked to maintain a diary about their obsessive thoughts under two conditions. In one condition, they were asked to suppress their thoughts, and in the other condition no such instructions were given. It was found that they reported more thoughts when instructed for thought suppression. Tsiolkovsky and Kirk, 1997. Researchers have also found that obsessive-compulsive symptoms increase in general because of thought suppression, and such people spend a lot of time and effort in thought suppression but remain unsuccessful in doing so. Purdon, 2004. Several researchers like Tsiolkovsky's, example, 1989, Rachman, 1997, have suggested that rather than the obsessive thought itself, it is the appraisal of that thought in terms of negative and catastrophic automatic thoughts that produces disturbances in subsequent compulsive behavior. Thought-action fusion has also been suggested to explain OCD fusion. Burl and Starchevich, 2005. Rachman and others, 2006. Shafran and Rachman, 2004. According to this explanation, people with OCD have an exaggerated sense of responsibility, and they interpret having a negative thought as equivalent to acting on it. For example, if a person with OCD has a thought of harming one's parents, they would appraise it as morally equal to actually harming their parents. That is, one's thoughts and actions have been fused together. To decrease the anxiety associated with this thought-action fusion, the person may indulge in compulsive behaviors. 91. Disorders of anxiety, panic and obsessions too. People with OCD also show cognitive biases and cognitive distortions. For example, research studies have shown that just like people suffering from other anxiety disorders, their attention is also focused on disturbing events that are part of their obsessions. Manika and others, 2003. Further, they lack confidence in their short-term memory and hence indulge in ritualistic behavior repeatedly that increases their compulsive behavior. Dar and others, 2000. According to researchers, example, Maureen Zamir and others, 2010, Bannon and others, 2008, such people also fail to inhibit motor responses and irrelevant information. Evolutionary factors. According to the evolutionary theorists, OCD has a role in our survival. For example, thoughts about contamination and subsequent actions to prevent it helps us to protect ourselves from potential infections and thus are valuable to our lives. Manika and Zinbarg, 1996, 2006. Also, displacement activities shown by many animals in stressful situations resemble compulsive actions of OCD, such as birds preening feathers in threatening situations. Kraske, 1999. 3.8 Treatment of OCD. The treatment options for OCD are as follows. Behavioral therapy. A combination of exposure therapy and response prevention has been found to be effective in treating OCD, Stein and others, 2009. In this treatment, the therapist along with the client prepares a hierarchy of distressing stimuli, which is rated by the client on a 0 to 100 scale in terms of the severity of distress or anxiety caused to the client. Then the client is asked to expose herself to stimuli given in the hierarchy, in ascending order of anxiety, that cause obsessive-compulsive responses, such as touching the doorknob. This is followed by response prevention where the client is asked not to engage in any ritual like washing hands to deal with the anxiety provoked by the obsession. The response prevention is important as the client can see that even when she did not engage in a ritual to reduce anxiety and obsessional thought, no catastrophe occurred, and the anxiety also reduced by itself. This observation helps the client to understand the futility of her obsessive-compulsive responses, thereby extinguishing them completely. Though some clients may not comply with this treatment, but many who do, show a symptom reduction of 50 to 70%. Abramowitz and others, 2009. Cognitive behavior therapy. Though cognitive behavior techniques, such as cognitive restructuring, has been found to be effective in treating OCD, however, these have not been found to be superior to behavior therapy. Abramowitz and others, 2009. Medications. Antidepressants, specifically those that affect the functioning of the neurotransmitter serotonin, have been reported to reduce symptoms by 25 to 35% in 40 to 60% of the patients with OCD. Doherty and others, 2007. In some cases of OCD which do not respond to the antidepressants, antipsychotic medications in small amounts have been found to significantly reduce symptoms. Block and others, 2006. However, a limitation of medication is that relapse occurs in 50 to 90% of patients on discontinuation of it. Doherty and others, 2007. In severe cases of OCD, where the patient suffers from the disorder for at least 5 years and does not respond to any treatment, psychotherapy or drug therapy. 92. Introduction to psychological disorders and disorders of anxiety and obsessions. Neurosurgical techniques have been suggested. However, these have been used sparingly because of adverse side effects. Mindus, Rasmussen, and Ruck and others, 2008. Lastly, evidence has been found that lesser number of exposure and response prevention sessions are required when the drug, D-cycloserine, is also prescribed to the patients of OCD. Wilhelm and others, 2009. Check your progress. 2.1. Differentiate between obsessions and compulsions. Thank you for listening. Please like and subscribe our channel. 2. What are the causal factors in the development of OCD? Thank you for listening. Please like and subscribe our channel. 3. Explain behavior therapy as a treatment option for OCD. Thank you for listening. Please like and subscribe our channel. 3.9 Summary. Now that we have come to the end of this unit, let us list all the major points that we have already learned. Generalized anxiety disorder is a state of chronic, excessive and unreasonable worry about multiple life events or activities and is caused due to genetic, psychological, chemical, behavioral or cognitive causes. The corticotropin-releasing hormone plays a role in GAD as it is an anxiety-producing hormone. CBT uses a combination of behavioral techniques such as progressive muscle relaxation exercises to relieve the physiological symptoms, such as breathlessness, muscle tension and cognitive techniques, in the treatment of GAD. Obsessive-Compulsive Disorder, OCD, is characterized by the occurrence of unwanted, intrusive obsessive thoughts and distressing images which are usually accompanied by compulsive behaviors. OCD lowers the quality of life and leads to significant functional impairment, and thus it is often considered to be one of the most disabling mental disorders. Behavior therapy is considered essential in the treatment of OCD, though medication is also used. 93. Disorders of anxiety, panic and obsessions 23.10 keywords. Gamma-aminobutyric acid or GABA, inhibitory neurotransmitter that helps to keep the feeling of anxiety away. Corticotropin-releasing hormone, CRH. The CRH plays a role in GAD as it is an anxiety-producing hormone. Generalized anxiety disorder, a state of chronic, excessive and unreasonable worry about multiple life events or activities. Obsessive-Compulsive Disorder, OCD, characterized by the occurrence of unwanted, intrusive obsessive thoughts and distressing images which are usually accompanied by compulsive behaviors. 3.11 Review Questions 1. Generalized anxiety disorder was earlier described as 2. A combination of exposure therapy and response prevention has been found to be effective in the treatment of 3. When corticotropin-releasing hormone is activated by stress or perceived threat that stimulates the, which in turn releases the 4. The psychoanalytic perspective of the occurrence of GAD as the 5. Failure in thought suppression as the cognitive causal factor for 6. What is the DSM criteria to identify OCD? 7. Discuss the treatment options for obsessive-compulsive disorder. 8. Describe the clinical features of GAD and discuss its causal factors. 3.12 References and further reading Abramowitz, J.S., Tolin, D.F., and Street, G.P., 2001. Paradoxical Effects of Thought Suppression, a meta-analysis of controlled studies. Clinical Psychological Review, 21, 5, 683-703. Amin, N., F.O.A., E.B., Coles, M.E., 1998. Negative Interpretation Bias in Social Phobia. Behave Res There. 36, 10, 945-57.